Good morning, everyone. Welcome to NEET PG, where you can crack all. Welcome to Unacademy, where you can crack all NEET PG exams with us, with our top educators, quality content, and have a great learning experience. So, guys, let's crack NEET PG together. A little about me. I'm Dr. Sasha Menon Remedius. I've done my MBBS from Father Muller Medical College, Mangalore. My MD in Anesthesia from Father Muller Medical College, Mangalore. I have 2 publications and 1 paper presentation in the field of anesthesia, and I've been working and teaching in Bangalore for the past 2.5 years. Today's topic is oxygen therapy equipment. I will be taking it in 2 parts. I have finished 1 part yesterday, and I'll be dealing with the second part today. Now, a little about Unacademy. It's one of India's largest online learning platform where you can get plus subscription and access to unlimited live and recorded courses from India's best educators. So guys, hurry and get your subscriptions quickly. Now, what will you get out of Unacademy? So basically at Unacademy, we have our daily live classes. So where you can chat with your educator, engage in discussions, ask your doubts and answer polls, and all this is while the class is going on. So while the class is going on, you can engage in active discussion. So basically when you go to a coaching institute, just a second, Shanti, this one, Shanti, this one. So basically when you go to a coaching institute, uh, you have to get up, get ready, make the effort to go there. Once you reach there, again you have to see that you have you have adequate place, that you're in front of your educator and you can clear your doubts, etc. So it's not always that your educator can clear everyone's doubts, because again for the educator they have a stipulated amount of time in which they have to finish class, and sometimes division of topics, etc., becomes a little difficult. Whereas here at Unacademy, you can chat with your educator, engage in discussion, ask your doubts and answer polls, and all this is while your class is going on. So while your class is going on, your doubts can be cleared, you can engage in discussions with your educator, etc. Now these are all structured courses. They are all in line with your exam syllabus. So the educators have researched on whatever is best from your exam point of view. The educators have prepared the syllabus based on that, and so that you all will be best prepared for NEET. Then we have our live tests and quizzes. So basically, uh, live tests and quizzes help you all to evaluate your performance on a regular basis, and hence you all can get a detailed analysis on your performance. Then it is one subscription, so there is unlimited access. You'll have, the most important part is there's unlimited access. So one subscription gets you access to all our live and recorded courses, and watch from the comfort of any of your devices. So wherever you all are sitting, whether you all are sitting at home or wherever you all are, as long as you're from the comfort of comfort of your house, from any of your devices, you all can access this platform. These are some of our top educators on the platform: Dr. Nikita Nanwani, Dr. Mohammad Azam, Dr. Preeti Sharma, Dr. Divesh Mishra. Now, Dr. Nikita Nanwani is a NEET PG mentor for radiology as well as mnemonics and concept, focusing on must-know topics. Now, those of you who want so those of you who mnemonics helps, this is a good way. But not it doesn't work for everyone, but if mnemonics works for you, that's excellent, and you all should actually actually try to make your own mnemonics, which will be even more helpful to you all. So these are some of the courses offered on our platform. And there are, so as you can see, there are various subjects that you all need to cover. I know it's not easy. There are so many subjects on the screen that you all need to cover, but we are here to help you all do that. And we, however much we can, we shall help you all cover these subjects. And there are various courses under each subject. Now those, now in MBBS, like during psychiatry, subjects like psychiatry, radiology, dermatology, anesthesiology, you all really didn't have to go into much detail, right, into these subjects. I know, so much detail was not required in these subjects. Now, for NEET PG, these subjects are allotted 11 marks each. But to score those 11 marks, it is not that it's easy to score. You have to go through these subjects, you have to revise these subjects. Then only those 11 marks are possible. So it's not that easy to get those 11 marks. But but it is not impossible. So like I said, uh, uh, we are here to help you all. So with those 11 marks, and so it's 11 marks per subject, and these are easy 11 marks if you all go through the subjects and revise these subjects. It's all about practice, revision, and studying. So the rest of the subjects like anatomy, physiology, pharmacology are allotted 44 marks each, and they can ask you anything from anywhere in these subjects, since they have been allotted 44 marks each. Whereas with these subjects like psychiatry, radiology, dermatology, anesthesia, they will not ask you, they basically will ask you a little more superficially as compared to these other subjects, because the marks allotted to are a little less. But to score those marks, you will have to go through the subject. These are some of the ongoing courses on our platform. Course on neurophysiology, GI surgery, cardiovascular thoracic surgery, larynx, respiratory system pathology. Now coming to the subscription. As you can see, there are 5 types of subscription on your screen. For those of you who are giving NEET PG this year, the 6-month subscription should suffice. For the rest of you, the 12 and 24 months is what I would actually recommend. So one is with these two subscription, they are more economical, because this is a one-time subscription. So after 6 months, if you don't like the subject you got, or if you want to change your subject, and you know you want to change a subject, you want to get into another subject. So from that point of view, this 12 and 24 months is what, you know, you don't have that buffer time. You will have to pay again if the 6 months is over. So if you don't clear or something, you will have to pay again. But here you have that buffer time with that 12 and 24 months. And also this 12 and 24 months gives you time to prepare. See, it's not easy. You're going to be doing this for the rest of your life. So you need to enjoy what you all are doing, right? So that's why from that point of view, uh, you'll need, like I said, you'll need to enjoy what you all will be doing. So from that point of view, uh, these subjects, this 1 year 2 years will give you time, because you'll be going through these subjects. So even what you chose earlier, you won't want it. Maybe you'll feel that you cannot do it. Maybe you feel that you won't be able to study it that much, but these other subjects you'll be able to study better. So it just depends. It actually, this buffer time does help you choose what you want. It helped me. So this is from personal experience. So and of course, it's not everyone's cup of tea to clear within 1, 3, and 6 months. So take your time. Nobody is going to ask you how long you took your NEET PG and why did you drop so many years, because at the end of it, once you specialize, nobody will ask such questions. It's all about practice from there once you get your PG seat. So as you can see, use my code at the bottom of the screen, SASHA, to avail your 10% discount. This is a 10% discount. It's applicable on all your subscriptions. Again, you can use my code, get your 10% discount. Okay, so now we'll revise yesterday's class and then we'll move on with today's class. So the topic is oxygen therapy and equipment. So patients, basically we discussed yesterday, patients who need oxygen therapy are basically patients who have had a cardiac or respiratory arrest, patients who are having hypoxemia, that is a PaO2 less than 60 or SaO2 less than 90, hypotension, low cardiac output and metabolic acidosis, respiratory distress. These are some of the people who require. Now, hypoxia is the lack of oxygen at the tissue level, and hypoxemia is a low oxygen tension in the arterial blood. Now, what are the causes? So the causes of hypoxia, it can be either arterial or failure of the oxygen hemoglobin system or various other causes, right? So how, so oxygen is either, it can be given alone or in a gas form mixed with air, helium or nitrous oxide, okay? So it can be administered as a partial supplement to patients, tidal or minute volume, or as the only source of inspired volume. So it can be during spontaneous ventilation. It is a supplement along with the patient's ventilation, whereas during what do you call it? Whereas during controlled ventilation, it is the only source of inspired volume. Now, how do you classify oxygen therapy devices? They are classified as So they are classified, oxygen therapy devices are classified as based on the performance of the device. So based on the performance, based on the flow delivered by the device, then based on the patient, and based on degree of dependence. Okay, so they are classified. So basically based on the performance of the device, they are classified as fixed and variable performance. So they are classified as fixed performance and variable performance. Fixed performance is basically your venturi mask, and variable performance is your nasal prongs and face mask. Flow, based on the flows delivered, they are classified as low flow and high flow. Again, low flow is your nasal prongs, face mask, CPAP devices, and nasal prongs, face mask, sorry, and your high flow is your venturi mask. Then based on the patient, it can be patient dependent or patient independent. Patient independent is basically your ventilators. Patient dependent is basically your CPAP devices, nasal prongs, face masks, venturi mask. Basically, it is on the patient. It needs the patient to function, right? Then the degree, it needs a patient to breathe, basically these devices, whereas patient independent like ventilators does not need the patient to breathe. Then degree of dependency, low dependency and high dependency. Low dependency is basically your face mask, nasal prongs. Medium, low, medium, so dependency is low, medium and high. So your low dependency is basically face mask, nasal prongs. Medium dependency is your CPAP mask and equipment, and high dependency is your non-invasive positive pressure ventilation, basically your ventilator. So now another concept is the peak inspiratory flow rate, right? The peak inspiratory flow rate while choosing the oxygen devices. So this is basic, that is required even for the next class. This thing class, what we did yesterday, we'll run through it once I finish these basics again. So now again we have this peak inspiratory flow rate. Now, what is this peak inspiratory flow rate? So, if the patient is breathing spontaneously with no reservoir and there is no additional oxygen fresh gas flow, then all the inspired gas will be from the room air, right? If the fresh gas flow is then increased to 100 liter per minute, so fresh gas flow is then increased to 100 liter per minute, then all the inspired gas would be taken from the fresh gas flow and the FiO2 will be same as the fresh gas flow. That is, a fraction of the inspired oxygen will be same as the fresh gas flow. If the fresh gas flow is then decreased, so one is no fresh gas flow. Second option was fresh gas flow at 100 liter per minute. So when there is no fresh gas flow, the patient will just be breathing room air. When the fresh gas flow is 100 liter per minute to the patient, the patient will receive only fresh gas flow. There will be no entrainment of room air. Now, if the fresh gas flow is decreased, made less than 100 ml per minute, okay, it is made less than 100 ml per minute, there will be a point at which so as the fresh gas flow is decreased from 100 ml per minute, a point will be reached at which the fresh gas will not meet the patient's requirements. So initially, as decreasing, it will be only fresh gas flow. Then a point will be reached where it will not be meeting the oxygen requirements of the patient. At this point, the patient will take in room air along with the fresh gas flow to make the oxygen requirements met. Okay, this occurs. So this point where there is entrainment of room air is when the fresh gas flow is less than the peak inspiratory flow. Okay, so the point at which the fresh gas is lower than the peak inspiratory flow, that is the time when the oxygen requirement is not being met of the patient and there will be entrainment of room air. So, for example, if a patient receives a fresh gas flow of 10 liter per minute, then at the start of inspiration, all the inspiratory gases will be taken from the fresh gas flow. However, entrainment of room air will occur when the inspiratory flow exceeds 10 liter per minute. Okay, so now I'll give you, see, if a patient is breathing at a rate of 10 breaths per minute, so now our patient is breathing at the rate of 10 breaths per minute. Tidal volume is 500 ml. Inspiratory to expiratory ratio is 1:2. Then each respiratory cycle will be of 6 seconds. This is obvious. So each respiratory cycle will be of 6 seconds with an inspiratory time of 2 seconds, right? So to inspire tidal volume of 500 ml over 2 seconds, the mean inspiratory flow should be so normal peak inspiratory flow rate is 60 to 70 ml per minute. Now, if the patient is receiving fresh gas flow of 10 liter per minute, then at the start of the inspiration, all the gas will be from the fresh gas flow. But however, entrainment of room air will occur when the inspiratory flow exceeds 10 liter per minute. So, what is variable performance devices or fixed or variable performance devices? So, supplemental oxygen. So basically oxygen is usually 100% is supplied, supplemental oxygen is supplied at a fixed flow, that is only a proportion of the inspired gas. Such devices are usually intended for patients with stable breathing patterns. As ventilatory demands change, variable amounts of room air will dilute the oxygen flow. So supplemental oxygen in these patients can be by a variety of devices. The effectiveness of each device. So the effectiveness of these devices, these variable performance devices, is determined by the capacity of each device to deliver sufficient oxygen at high enough flow rate to match the patient's spontaneous inspiratory flow rate. In a non-intubated patient breathing in an open system, the capacity of the oxygen therapy device to meet the inspiratory flow rate will determine how much room air will be entrained. So the FiO2 delivered from the oxygen source will be diluted by room air. Therefore, the oxygen delivery systems are categorized as either variable performance, that is no control on FiO2, or high flow fixed performance, that is controlled FiO2 systems. So variable performance, there is no control on room air, right? So as the ventilatory demand changes, variable amounts of room air. So the variable performance, these are patient dependent. So because the ventilatory demand change, variable amount, so this is patient dependent. It depends on the patient to maintain, depending on the patient's peak inspiratory flow rate, to maintain the FiO2, and it changes with the respiratory pattern, the amount of room air entrained. Now the high flow, the fixed performance equipment. So the inspired gas at a preset FiO2 is supplied continuously at high flow. So they are usually considered as patient independent because regardless of the change in the respiratory parameters, the patient will receive a constant predetermined uh, inspired oxygen concentration. Okay, so these are generally considered as patient independent. So example for this is Venturi mask. The earlier one was face mask and nasal prongs. Okay. So inspired gas at a preset FiO2 is supplied continuously at high flow by providing sufficiently large reservoir. So the variable performance devices are nasal cannulas. Now what are the factors that control the FiO2 in these nasal cannulas? Basically equipment factors. So the factors that control the FiO2 are, so first of all, it is available either as a blind-ended soft plastic tube with an over-the-head elastic, or a dual flow with under-the-chin adjustment. Sizing is available for adults, children, and infants. Cannulas are connected to flow meters with the small bore tubing and can be used with a bubble humidifier. So now the factors which control FiO2 in these variable performance devices. So during normal respiration, the rate and tidal volume varies with each breath. Okay, the exact dilution, the exact dilution of oxygen by air cannot be known due to irregular respiratory pattern. As a result of this, the FiO2 not only varies with each breath but also varies from patient to patient, obviously. So the factors which control FiO2 in these patients are, one is equipment factors. So equipment factors are oxygen flow rate, mask volume, uh, and the volume of the reservoir bag, fit of the mask on the face, size and placement of the vents. So the equipment, so basically fit of the mask, the flow rate, the mask volume, volume of the reservoir bag, all these. Then patient factors. Patient factors is basically the respiratory rate, the tidal volume, the dead space, peak inspiratory flow rates, anatomical reservoir. Anatomical reservoir varies with the size of the subject. In infants, the dead space is 3.3. It decreases to the adult value of approximately 2 ml per kg by the age of 6 years. Then additional factors like presence, whether humidified gases or So humidified gases, vapors, etc. Additional factors. So the nasal cannulas can be rapidly and comfortably placed on most patients. Patients on long-term oxygen therapy most commonly use a nasal cannula. The appliance is usually well tolerated and it allows speech, eating and drinking. The factors affecting the actual FiO2 delivered to adults by nasal cannulas. So it is determined by, like I said, uh, the oxygen flow. So the equipment factors. So over here comes your equipment factors, your patient factors and your other factors. So the patient factors are like the inspiratory flow rate, the tidal volume, etc. So nasopharyngeal volume, oxygen flow, etc. Now nasal cannula flow. Nasal cannulas can be expected to provide an FiO2 of up to 30 to 35% with normal breathing and oxygen flows of 3 to 4 liter per ml. So they provide an FiO2 up to 30 to 35 with normal breathing and oxygen flows of 3 to 4 ml liter per minute. FiO2 levels of 40 to 50% can be attained with oxygen flows of greater than 10 liter per minute for short periods, right? So FiO2 levels of 40 to 50%, they can be obtained with oxygen flows greater than 10, but only for short periods. But generally, FiO2 of only 30 to 35%, and oxygen flow is generally kept at 3 to 4 liter per minute. Uh, so why a cannula flow of more than 5 liter per minute is poorly tolerated? So usually flows greater than 5 liter are poorly tolerated because the discomfort of gas jetting into the nasal cavity, and there is drying and crusting of the nasal mucosa, right? So there is no benefit because anyway rumor is being entrained. So there is no benefit per se, only disadvantages. So this is your nasal cannula with the ear behind the ear placement. So this is the flow meter. To this lower part over here, a humidifier will be connected to which the oxygen will be attached. This is the here. So the oxygen tubing will be attached here, and this is the knob to connect to modify the flow meter. So nasal mask. So nasal cannula. So they are basically, you can say, low flow variable performance devices with no capacity. Okay, so that's how. Sorry, that's how we will describe a nasal cannula of nasal mask. Low flow variable performance with no capacity. This will be your nasal mask and nasal cannula. Uh, Now, nasal mask, it is a hybrid of the nasal cannula and a face mask. Nasal masks have been shown to provide supplemental oxygen equivalent to the nasal cannula and under low flow conditions for adult patients. Patient comfort and compliance is more home use for obstructive sleep apnea, and snores can develop around the external nares of long-term nasal cannula use. Sores can develop, see, because over here sores can develop. So this is a device that is used for OSC. Now non non-reservoir oxygen mask. It is simple, no reservoir mask, disposable, lightweight plastic device that covers the nose and the mouth. The face seal is rarely free of there is a lot of leak that is produced, so patient receives a mixture of entrained room as well as pure oxygen. So factors that so for pediatric face masks have a low capacity of 70 to 100, and the adult face mask generally of 100 to 250 ml capacity. And these face masks provide a FiO2 of about 35 to 60 depending on the fit. Flow rates are usually 5 to 10 liter per minute. Caution should be taken when using a simple mask where accurate delivery of low concentration of oxygen is required. So the factors affecting oxygen bar entrained air ratio depend on the size of leak, the oxygen flow, and the breathing pattern. So a minimum oxygen flow 5 liter per minute is applied to face mask to avoid rebreathing and excessive respiratory work. Disadvantages are wearing the mask for long term is uncomfortable, speech will be muffled, eating and drinking are difficult. So with flows of 5 liter per minute, FiO2 is about 0.3, and with flows of about 7 to 8 to about 10, it is 0.6. So the non-reservoir mask is used for patients who require higher level of oxygen than nasal cannulas. This is the non-rebreathing simple face mask. Now your reservoir masks, they incorporate a gas reservoir, two types, partial rebreathing mask and non-rebreathing mask. The non-rebreathing mask basically have valves. One valve is located, so the partial rebreathing mask refer to the part of the patient's expired tidal volume is refilling the bag, so there is rebreathing occurring. Usually it is a dead space gas that is being entrained, and hence there is not much of rebreathing occurring. The non-rebreathing mask basically has valves which prevent rebreathing. They're flap type of valves. One is located between the bag and the mask, and the other on the mask exhalation ports, right? Now the ones that are located on the mask exhalation ports are flap valves, so they will not inhibit the gas from going out. Now disadvantages of reservoir mask, there is always again a lack of good facial seal system, a relatively smaller reservoir which can affect the delivered oxygen concentration, and the key factor to successful application of the mask is to use sufficient flow of oxygen so that the reservoir bag should always be kept partially full during inspiration. So the FiO2 with the typical flows for oxygen are higher in this 10 to 15 liter per minute, and the FiO2 varies from 0.35 to 0.6 with oxygen flows up to 10 liter per minute. It may even approach 1 with the flow of 15 liter per minute. So the indications are MI, carbon monoxide poisoning, trauma. These are the various types. Now coming to the fixed performance high flow equipment. Okay. So anesthesia bag or bag mask valve system, the basic design follows that of the non-rebreathing reservoir bag. Okay. So self-inflating bags like Ambu consists of a football-sized bladder, usually with a oxygen inlet reservoir. Right, so it has a reservoir bag, a gas inlet, a self-inflating bag, and a non-rebreathing valve. So these are the fixed performance. So AMBUS basically stands for artificial mandatory breathing unit or air bag mask unit. I'll talk about it in detail next class mostly. Anesthesia bags are 1, 2 or 3 liter non-self-inflating reservoirs with a tailpiece gas inlet. So masks are designed to provide a comfortable uh, leak-free seal for manual ventilation. The inspiratory expiratory valve systems can vary. The flow of the reservoir should be kept high so that the bags do not deflate substantially. So when using an anesthesia bag, operators may frequently have to adjust the oxygen flow and exhaust valve spring tension to respond to changing breath patterns or demands. The most common system for disposable and permanent self-inflating resuscitation bags uses a unidirectional gas flow. There are limits to the ability of each system to maintain its fixed performance characteristics. The delivered FiO2 can equal or approach 1 with either anesthesia or self-inflating bags. So this is your ambu bag. So this is a self-inflating, so there is no standard resuscitator for all patients. They are supplied in 3 sizes. So it is supplied in 3 sizes. Okay, adult has a capacity of 1600. Excuse me. So the adult has a capacity of 1600 ml and is capable of delivering a tidal volume of around 600 ml. It can be used in adults weighing more than 30 kg. So basically, okay. Then the child, it has a capacity of around 500 ml and can be used in patients between 7 to 30 kg. The maximum tidal volume that can be delivered with adult is 1000 ml, child is 350 and infant is around 200 ml. So expiratory resistance is lower for flows less than 10 liter. Inspiratory resistance is also present. So the design is a manual resuscitators. This is the thin walled compression bag, which this allows for lung compliance and feel. It is a self-expanding bag, a refill valve and a patient intake valve. Okay, so a refill valve is also present. So it has an extremely low resistance for unimpeded airflow. So there's extremely low resistance. Unique single shutter valve system for reliable functionality. Some of them have a medication port too for medication for giving medication. There is a fast recoil time which allows for for rapid ventilation. So it has a non-rebreathing patient valve and a PEEP. So it has a, here is the non-rebreathing. So it has a patient intake valve, that is non-breathing valve, and a expiratory diverter. So over here is an expiratory diverter. Okay. Optional components, there can be a PEEP valve too and a mechanism for scavenging. Now the self-inflating bag, it is cylindrical, sometimes shaped like a ball. It is made up of silicone and is cream. So this is made up of silicone and is cream in color. The bag refill valve, there is a bag refill valve. It is a one-way flap valve which is fitted to the inlet of the self-inflating valve. So over here there is a bag refill valve. Okay, bag refill valve. Uh, when the bag, so when the bag is squeezed, the gas pressure inside the bag causes the flap valve to close. This this prevents escape of gas through the inlet. When the bag is released, its self-inflating characteristics cause entrainment of fresh gas from the respirable gas inlet. Yeah, this may normally be either air, oxygen, or a mixture of both. So, in a spontaneously breathing patients are allowed to breathe only the contents of the system if the mask seal is tight and the reservoir is adequately maintained. Operators must adjust gas flow to the bag. So this is for the anesthesia bag system, that is your Mapleson systems. So operators must adjust gas flow to the bag to accommodate for any changes in ventilation. This we have already discussed in a different class. I have discussed the Mapleson systems. So a primary concern for clinician using mask bag system is aspiration. Failure to maintain adequate oxygen supply in the reservoir and inlet flow is another concern. So the spring-loaded valve of anesthesia bags must be adjusted appropriately to prevent over-distension of the bag. Self-inflating bags do not look different when oxygen flow to the unit is inadequate, and they will entrain room air into the bag, thus lowering the delivered FiO2. But generally they are used for resuscitation. So air entrainment venturi mask. So what is this venturi effect basically? Right? So venturi effect is based on Bernoulli's principle. It states that it is basically the relationship between velocity and pressure exerted by a moving liquid. So as the velocity of fluid increases, the pressure exerted by the fluid decreases. Okay. So Bernoulli's principle, venturi effect, is based on Bernoulli's principle, velocity and pressure. So as the velocity of a fluid increases, pressure exerted by that fluid so as the velocity of a fluid increases, the pressure exerted by that fluid will decrease, right? So the gas delivery system with air entrainment mask is somewhat different than with an oxygen reservoir. Okay. So the goal in venturi mask is to create an open system with high flow above the nose and mouth and with a fixed FiO2. Okay, so oxygen is directed by small bore tubing into a mixed jet. The final oxygen concentration depends on the ratio of air drawn in through the entrainment ports. Okay, so now how does this venturi affect? How is this Bernoulli's principle uh, applied to gases? So that is for liquid. As the velocity of a fluid increases, pressure exerted by that fluid decreases, right? So when a fluid flows through a constriction, the fluid velocity must increase to satisfy the equation of continuity. Due to the principle, so uh, the principle of any gain in kinetic energy due to the increase in fluid velocity has to be balanced by a drop in pressure distal to the constriction, right? So any drop in pressure, so because the kinetic energy is increasing, so when the fluid is flowing through a narrow constriction, it is increasing, right? The kinetic energy is increasing, the velocity is increasing, so kinetic energy is increasing. This has to be balanced by a decrease in uh, energy post the constriction. So the Venturi principle describes how a second fluid can be entrained into the stream of the first. It can be either done through a coaxial system or through a side arm opening into the area of low pressure. So there are other devices also which are based on this, like other than Venturi masks, which are based on this principle. So basically this Venturi mask, it is a high flow fixed performance device. So it is high flow and fixed performance device. An air entrainment mask contains a jet orifice and an air entrainment ports and is designed to fit over the nose and mouth. So so this is the oxygen that is coming. Okay, this is the removal adapter, this is the flexible tube, this is the exhalation port. So it has an air entrainment port and an air entrainment port, entrained room air and 100% oxygen. So basically it is based on the principle that uh, the oxygen is supplied to the mask through a narrow bow oxygen tubing under pressure. So oxygen is supplied to the mask under pressure. When oxygen under pressure is forced through a small jet orifice entering the mask, so it is forced through a small jet. This is the small jet orifice. A negative pressure is created which causes room air to be entrained into the mask through the apertures in the venturi barrel. So in the room air gets entrained through the apertures in the venturi barrel. The resultant is the air oxygen mixture containing the prescribed O2 concentration flows into the face piece for patient breathing. Alright, so this oxygen is already a prefixed FiO2. When it passes through this narrowing, it causes a pressure drop over here. So here the pressure is increased, so there will be a pressure drop here. Because of the pressure drop here, it will entrain air from the environment and this will flow to the patient, right? Due to the high flow rates, the excess gas flushes out the expired carbon dioxide. So it is a high flow rate. So the excess gas will flush out the carbon dioxide through the holes on the side of the mask. As a result of this, there is no rebreathing or no increase in dead space. When oxygen flow is increased, more air is entrained to maintain a constant oxygen concentration. The system is called a high flow with oxygen enrichment. Okay. So this entrainment is based on Venturi principle. So despite the high flow concept, FiO2 can vary up to 6% per setting. So the variation in FiO2 can be 6% per setting. So the patient whose hypoxemia cannot be controlled at lower FiO2s, basically patients in whom hypoxemia cannot be controlled with lower FiO2 devices like nasal cannulas. So the causes of increased FiO2 than expected during use of Venturi mask. So FiO2 can be increased if the entrainment ports are uh, obstructed by the patient's hands, bed sheets, water contents, etc. Then there can be an increase in the FiO2 need of the patient. So Venturi masks are basically the venturi is the part of the mask so that the air is entrained into the mask. So this is the narrowing, and from these ports, so this is the narrowing through which the oxygen enters, and from these ports air is entrained. The masks are color coded and labeled with inspired oxygen concentration that they will deliver and the flow of oxygen, that is, so this is a color coding. So based on this color coding, they are labeled as a amount of oxygen that they will deliver and the flows that are needed to be kept to deliver that particular FiO2. A known FiO2 can also be delivered to the patient breathing spontaneously with an endotracheal tube by attaching the venturi device to the T-piece. So if the patient has an endotracheal tube, but by attaching a venturi device to the T-piece, this can be gotten. This similar effect can be gotten. So this is the Venturi mask principle. So the Venturi oxygen delivery device has two variables, oxygen flow and entrainment ratio, right? So it is based on the oxygen flow and entrainment ratio, two variables. So the oxygen flow, the entrainment ratio is set by the manufacturer. Any back pressure or suction will change the entrainment ratio and more air will be entrained. If all the oxygen that is delivered to the mask takes part in total flow, it is possible to deliver mathematical in ratio. So entrained airflow is given by the equation. This entrained airflow is given by oxygen flow from wall into 1 minus FiO2 divided by FiO2 minus 0.2. This is the amount of air that is entering. You all don't need to know this. This I have just given. So this is the Venturi mask in use. This is adjustable Venturi valve. This is the color coding. So this is the Venturi mask flow rates. So blue, the inspired concentration is usually 24%. Oxygen flow to be kept is 2 to 4 liter, and total gas flow will be around 51 to 100 liter per minute, right? The white will be inspired concentration is 28 and oxygen flow is usually 4 to 6. So we cannot keep 100 liter per minute oxygen flow. Okay, total gas flow is different, but 100 liter oxygen flow, that is what was, I think, one of the doubts. It's not 100 liter oxygen, it's 10 liters of oxygen that can be given. Yellow is 35, 8 to 10 liter per minute oxygen. Red is 40% FiO2. So this inspired concentration is fractional FiO2 basically. Fractionally inspired concentration of oxygen. Green delivers FiO2 of 60% and 12 to 15 liters per minute of oxygen flow will need to be kept. Air entrainment nebulizers. So large volume, high output or all-purpose nebulizers have been used in respiratory care for many years to provide a blast mist with some control of the FiO2. These units are commonly placed on patient following extubation, basically for aerosol production. So these are basically nebulizers which have been designed, if possible, to give a fixed control. Like the entrainment mask, like the Venturi mask, the nebulizer uses a pneumatic jet Venturi effect and adjustable orifice to vary the entrained air for a FiO2 level. So it's the same principle, just that over here there is nebulization that is occurring. Okay, it's the same Bernoulli's Venturi principle. So nebulizer systems can be applied to the patient with many different devices, including a tracheostomy, a face stent, a T-piece adapter. They can be attached via large bore tubing to the nebulizer. So this is your nebulizer. So it has a very similar effect to the Venturi. Of course, you get the nebulizers without this, but these are the nebulizers with the adjustable nebulizers. So oxygen hoods, these are basically used in pediatric patients. They cover only the head, allowing the infant to access the infant's lower body while still permitting the use of a standard incubator or radiant wand. These are basically used for infants. It is ideal for short-term oxygen therapy for newborns and infants. Normally, oxygen and air are premixed by an air-oxygen blender device passed through a humidifier. So, in these patients, you have to be very careful that the baby is kept warm and not. So, it has to be humidified. There is no attempt to completely seal the system, as a constant flow of gas is needed to remove carbon dioxide. So, there is no seal. It's just a hood, like I showed. See, it's just a hood. So, there is no seal as such over here, right? So the air can go in and out. So there is no seal because there is no attempt to completely seal the system, prevent a proper seal like a face mask, Venturi mask. because carbon dioxide has to be removed continuously. So a minimum of more than 7 liter per minute of flow is required for uh, these hoods. Then hood inlet flow of 10 to 15 liter per minute are adequate for majority of the patients. So helium oxygen therapy. Heliox mixtures have a number of medical applications. Helium is premixed with oxygen in several standard blends. So the most popular mixtures of helium and oxygen are 80-20, 70-30. They are available in large size compressed gas cylinders. The code for a heliox cylinder is white and brown. In anesthetic practices, pressures needed to ventilate patients with small diameter tracheal tubes can be substantially reduced when a heliox mixture is used. So small diameter tracheal tubes basically they increase the ventilating pressures a lot, right? So that is why the pressures can be halved when this mixture is used. So temporary relief it provides temporary relief in patients with acute distress from any supraglottic obstructing lesions like a subglottic edema, foreign body, tracheal tumors, etc. So this is a heliox cylinder. So patient's work of breathing can be reduced when heliox is delivered via the mechanical ventilator. It is non-invasive or via an artificial area. So non-intubated patients commonly receive heliox therapy via mask with a reservoir bag. So non-intubated patients, they normally receive heliox via mask with a reservoir bag. Hyperbaric oxygen. So hyperbaric oxygen therapy uses a pressurized gas chamber. So the gas chamber is pressurized to expose the patient to oxygen tensions that exceed the ambient barometric pressure. It is more than 760 millimeter of mercury. Around 3 bars hyperbaric oxygen is normally used. Now the indications for hyperbaric oxygen include decompression with sickness, gas embolism, gas gangrene, carbon monoxide poisoning, and treatment of certain wounds like diabetic foot. So this is a hyperbaric oxygen therapy chamber. These are the hyperbaric oxygen therapy chambers. So guys, that was on today's class on oxygen therapy devices. So tomorrow we'll deal with vaporizer and we'll have a short quiz on these oxygen therapy devices, etc. So do log in. Tomorrow the class will be in the morning. And today we dealt with the Venturi mask, uh, nebulizers, the oxygen chambers, and oxygen hoods. So oxygen hoods are basically used in infants, and minimum of seven liter flow, 7 liter of flow is required for these oxygen hoods, right? So and they are not sealed. So in everything else, we are very worried about the seal being created, that there is no leakage of air. But over here, we cannot really be worried about the seal that is being created because we cannot worry much about the seal that is being created by these. We cannot worry much about the seal that is being created because this carbon dioxide has to be pushed out. So the seal wise, we have to be careful. Venturi mask, of course, they are high flow variable. They are high flow variable devices. The Venturi masks are high flow fixed devices. They deliver fixed amount of FiO2. They function on the Bernoulli's principle, and first fixed amount of FiO2 is given, and there is air entrainment, and because of the high flow of air, any carbon dioxide is exhaled through the vent ports that are present in the face mask. So the Bernoulli's principle is whenever there is a decrease in diameter, the gas will go with extra energy. There will be a drop in pressure post the constriction, and where there can be, because of the drop in pressure, there will be entrainment of air. That's about it for today. Do use my code, guys, SASHA, to avail your 10% discount. My next class is on vaporizers at around 9:15. Do log in. Thank you, guys.